Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to the Deep Dive. We're here to take that stack of dense source material and really distill it down into the insights you need. Today, we are opening a dive locker door into something truly terrifying, one of the most unpredictable emergencies in the operating room, malignant hyperthermia, or MH for short.
Yeah.
You can think of it as a rare, life-threatening pharmacogenetic disorder of skeletal muscle.
Which is a mouthful.
It is. So let's strip away the jargon. It's basically a genetic time bomb where common anesthetic drugs, things used safely millions of times a day, suddenly turn into a catastrophic poison.
And to really get the stakes, you have to look back to the 1960s when this was first even recognized.
Right.
Famously, he was a patient who pointed out that, a bunch of his family members had died unexpectedly under anesthesia. That's what led to the formal identification. And before we understood it, before we had any real treatment, the mortality rate for this was just shocking. It was often over 80%.
80%. That's almost a guaranteed fatality.
Well,
And yet today, that number is below 10%, often below 5%. That dramatic shift is really the story we're tracing today.
the primary culprits, the triggers for this crisis, are the volatile anesthetic agents.
Things like isoflurane, sevoflurane.
Exactly. And the other big one is the depolarizing muscle relaxant succinylcholine.
What's so fascinating, though, is that this isn't just an operating room problem.
No, it's not.
In people who are susceptible, really intense physical exertion or just, severe environmental heat can also flip this same metabolic switch.
That's right. So our deep dive mission today is to unpack the molecular mechanism, this calcium catastrophe, as it's called, and really understand why this genetic time bomb only goes off under certain circumstances. And we're going to focus heavily on the one revolutionary drug that made that 80% survival rate possible.
Dantrolene.
Dantrolene.
Okay, let's get into it. The core mechanism. What is fundamentally broken inside the muscle cell that turns standard anesthesia into an absolute disaster.
The root issue is a complete breakdown of intracellular calcium control. It's all about calcium within the skeletal muscle cells.
So just too much of it.
An uncontrolled, massive, excessive increase of calcium that is suddenly just dumped into the muscle cell.
And where is it all coming from?
It's released from the muscle's own internal calcium storage tank, the sarcoplasmic reticulum, or SR. It comes through a very specific channel.
The ryanodine receptor.
The ryanodine receptor type 1, or RR1. In people susceptible to MH, this channel, this RR1, it's faulty. And the anesthetic triggers, they basically blow the emergency valve wide open.
Okay, so if calcium is the spark plug that makes a muscle contract, flooding the cell with it means the engine is just stuck on maximum throttle?
Exactly.
What happens then?
Well, that excessive sustained calcium causes a massive muscle contraction, and it fuels a severe hypermetabolic crisis. The body just goes into total overdrive.
That's the hyperthermia part.
That's the heat, yeah. Uncontrolled heat generation. We see massive oxygen consumption and, crucially, excessive carbon dioxide production, hypercarbia. And this all just rapidly depletes the cell's energy and leads to a severe acidosis.
It's like the body is literally burning itself out from the inside. We know this is inherited, right?
Yeah.
Linked to mutations in that RYR1 gene.
It is. It follows an autosomal dominant inheritance pattern, so if you get the gene, you're susceptible.
But this is where it gets really interesting, where the paradox comes in.
Right. There's this huge gap between the genetic risk and what we actually see in the clinic.
We're talking about a genetic prevalence, people who actually carry the trait, as high as 1 in 2,000, maybe 1 in 3,000.
And some studies suggest it could be as high as 1 in 400 in certain localized areas.
But the actual clinical incidence, the number of crises that happen, is way lower. Maybe 1 in 15,000, sometimes only 1 in 100,000 anesthetics.
It's a massive discrepancy.
So why? Why is the gene so common but the event so rare?
That paradox is explained by something called incomplete penetrance and variable expression, meaning just having the faulty RR1 gene makes you susceptible, but it doesn't guarantee a reaction every time. In fact, on average, a susceptible person might have 3 perfectly normal, uneventful anesthetics before that perfect storm of factors finally flips the switch.
It's also striking how demographics seem to play a role. It's reported to be about 3 times higher in children than in adults,
And twice as often in males compared to females.
which suggests there's something else going on, maybe growth factors or muscle mass or hormonal status, something hidden.
That high variability is what makes recognizing it in the moment so hard. You're racing against the clock, and the first symptoms can look like a lot of other things.
Like sepsis or thyroid storm.
Or even neuroleptic malignant syndrome, a lot of overlap.
So for the team in the OR, if a crisis starts, what is the single earliest signal that screams malignant hyperthermia?
You have to prioritize the increased end-tidal CO2, the hypercarbia.
Carbon dioxide.
Yes. This is the earliest, most sensitive sign. That hypermetabolic furnace inside is running so hot, the body is just producing huge amounts of CO2. You'll see the monitor readings just spike, maybe from normal levels up to 50 or even 100 millimilli G, even though the ventilator is working perfectly.
What about the physical signs? What do you see next?
The absolute hallmark is muscle rigidity. Generalized rigidity is almost pathognomonic. It's almost guaranteed to be MAH. And a very specific red flag is masseter muscle rigidity, or MMR jaw stiffness, especially in kids after getting succinylcholine.
So if you see that, you should be worried.
Very. Now, not all kids with MMR go on to a full crisis, but about 20% of them do.
And the symptom in the name hyperthermia, that's often a later sign.
It is, which is why waiting for a high temperature is a fatal mistake. The key detail is the rate of temperature increase, the speed.
How fast?
We're talking 1 to 2 degrees Celsius every 5 minutes. The patient is just rapidly overheating. Once that core temp gets above 42 degrees Celsius, they're at severe risk for a massive internal clotting, what we call DIC.
And all that internal chaos, it breaks down the muscle tissue itself, right? Which leads to another cascade of problems.
That muscle breakdown, rhabdomyolysis, is lethal. The cell contents just spill out into the bloodstream. You see a huge spike in creatine kinase, and myoglobin, a muscle protein, floods the urine. It often turns it the color of cola.
And the most dangerous part of that?
Hyperkalemia, a rush of dangerously high potassium. That high potassium can cause fatal arrhythmias. It can stop the heart.
So every minute counts. You can't sit there wondering if it's just a fever.
Not for a second.
So if the crisis is averted, how do you confirm that someone is susceptible after the fact?
There are 2 main methods. The gold standard is still the in vitro contracture test, or IVCT.
But what does that actually involve? It sounds invasive.
It is. It requires a surgical muscle biopsy. We have to take a sample of living muscle tissue.
Wow.
Then that tissue is exposed to halothane and caffeine in a lab to see if it contracts abnormally. It's incredibly accurate. The European protocol is 100% sensitive, but it's a big deal and only done at a few specialized centers.
So why not just do a genetic test? You just need a blood sample for that.
And that's the critical limitation. Genetic testing has surprisingly low sensitivity for MH.
Low sensitivity meaning?
Meaning you're looking for a specific mutation in the RYR1 gene or another one called SANNA1S. If we find a known one, that's great. We can screen the whole family easily. But up to 50%, half of people who are susceptible do not carry a known pathogenic variant in the genes we currently test for.
So let's translate that for the team on the floor. A positive genetic test confirms it,
Yes.
but a negative genetic test.
A negative genetic test cannot definitively rule it out. If your clinical suspicion is high, that patient still needs the gold standard biopsy.
Which brings us to the moment of truth.
Yeah.
Emergency management. You suspect it's happening. Time is the enemy. You have to treat.
Immediately, you treat empirically. The first step is simple. Discontinue all triggers. Turn off the volatile agents. Don't give any more succinylcholine.
Step 2, clear out the poison.
Exactly. Hyperventilate the patient with 100% oxygen at very high flows, 2 to 3 times the normal rate. And you use these special activated charcoal filters.
Vapor clean.
Right, vapor clean, to physically scrub the residual gas out of the breathing circuit fast.
And then step 3, the drug that changed everything.
You give dantrolene sodium. It's the only specific drug for MH.
And how does it work? What's its tactical advantage?
It acts directly on the skeletal muscle. It antagonizes that faulty RIR1 channel we talked about. It inhibits the calcium leak. It effectively slams that emergency valve shut and stops the whole cascade.
And its advantage is that it's specific.
Very specific. It only targets skeletal muscle. It has no effect on the contractility of the heart or smooth muscle.
Which is critical. You're not risking cardiovascular collapse to fix the muscle problem. What's the dosing protocol?
The initial dose is 2.5 milligrams per kilogram, given rapidly, IV, and you repeat that dose every 5 to 10 minutes until the symptoms start to go away. But there is a ceiling. If you've given 10 kilograms with absolutely no clinical improvement, then the diagnosis of MH is probably wrong. You need to pivot hard to those other diagnoses.
Now, this brings us to what I've heard called the reconstitution nightmare. The original version of this drug was a logistical horror show in an emergency.
It was a panic multiplier. I mean, the traditional form, it came in these little 20 milligram vials. Each one needed a staggering 60 milliliters of sterile water, and you had to shake it like crazy to get it to dissolve.
So for a normal-sized adult,
For an 80 kilogram adult, you'd need 10, maybe 12 vials just for the initial dose.
imagine that. The patient is crashing, the CO2 monitor is screaming, and you have people just desperately shaking a dozen bottles of this stuff.
It was chaos. Fortunately, pharmaceutical innovation stepped in. The newer formulation, Ryanodex, is a complete game changer.
Oh.
It has 250 milligrams in a single vial, and it only needs 5 milliliters of sterile water to dissolve.
So one vial instead of 12.
One vial. It dramatically streamlines the whole process, reduces the fluid load on the patient, and it lets the team focus on the patient, not on a chemistry experiment.
Okay, so gantrelline stops the engine from redlining. But what about the damage that's already been done?
Supportive care is just as critical. You have to treat all the complications from that hypermetabolic state.
Starting with the heat.
Right. You initiate active cooling if the core temp is above 39 degrees Celsius or climbing fast. You can use ice packs on the surface or internal cooling.
Like cold 5e fluids.
Exactly. Refrigerated crystalloid solutions, like 2 liters of 4 degrees Celsius fluid. But crucially, you have to stop active cooling once the temperature falls below 38 degrees so you don't overshoot and cause hypothermia.
And then there's the potassium problem from the muscle breakdown.
That hyperkalemia is an immediate threat of cardiac arrest. The treatment is urgent. You give IV calcium to stabilize the heart's membranes, then insulin and glucose to push potassium back into the cells, and sodium bicarbonate to help fix the acidosis.
And what about saving the kidneys from that cola-colored urine?
Aggressive fluid resuscitation. That's essential to prevent acute kidney injury. We want urine output over 1 milliliter per kilogram per hour, and we alkalinize the urine with bicarbonate, which helps stop the myoglobin from clogging up the kidneys.
We have to mention one critical life-threatening drug interaction before we move on.
This is a hard and fast rule. You must avoid calcium channel blockers, specifically verapamil or diltiazem. You do not give them with dantrolene.
Why not?
That combination can cause fatal hyperkalemia and total cardiovascular collapse.
But there's a really important nuance here for the clinical team.
Yes, if the patient is already taking those drugs chronically when the crisis starts, you do not withhold the dantrolene.
The cure is more important than the risk.
Precisely. The need to stop the MH crisis outweighs the risk, but you have to monitor that patient incredibly closely because the potential for collapse is still very real.
Okay, finally, post-crisis. The patient survives the initial event. They have to be monitored for reoccurrence, right?
Yes, the risk of recrudescence or reoccurrence is high, up to 25% of patients, so they have to be monitored in ICU for a minimum of 24 hours. And we continue maintenance dantrolene for at least that long to keep that RYR1 valve shut.
And for patients who are known to be susceptible, there's no reason for them to ever go through this again.
That's the beauty of prevention. For a known MH patient, the key is just trigger-free anesthesia. And if they get that, dantrolene pretreatment is not necessary anymore. And for that immediate life-saving advice, there's a fantastic resource, the Malignant Hyperthermia Association of the United States, MHAUS. They run a 247 emergency hotline that clinicians rely on.
So what does this all mean for us? The story of malignant hyperthermia is really this powerful lesson in pharmacogenetics. It shows how one single specific genetic flaw, a busted calcium valve in the muscle, can turn standard, everyday drugs into these rapid-acting toxins.
The knowledge we've gained, and especially the introduction of dantrolene, has just fundamentally changed the odds. It shifted survival from a terrifying 1 in 5 to a much better 19 in 20. But the fact that the genetic prevalence is so high and the clinical incidence is so low, it just shows us that we're still missing pieces of the puzzle. We don't really know what the final trigger is that flips that switch.
And that unknown is the key. So given that high genetic prevalence, up to 1 in 400 in some areas, and the fact that most susceptible people have multiple uneventful surgeries before a crisis, consider this. If we know that environmental heat and strenuous exercise can trigger MH outside of the operating room, what subtle, persistent, non-anesthesia stressors in our daily lives could be pushing a genetically predisposed individual into a subclinical hypermetabolic state right now, or that life-saving dantrolene cart is miles and miles away? That's something worth mulling over.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.